Sandy, you won't have any trouble with my name. People have trouble spelling my first name, but they don't have trouble pronouncing it. So I think we'll
No,
be
you're
fine.
good. And it's like one of my weird quirks that I've never been, it's a thing for me that I've always had trouble with. So
Sure.
yeah. And what's interesting is I can remember if they have a dog, their favorite pizza,
Oh, sure.
but
Oh, sure.
their names, forget about it. Yeah,
Yeah.
absolutely can't remember. And then
Yeah.
I have, some pronunciations. And
Yeah.
I'm from, yeah.
I have that too. And it makes it hard to know if I'm having early dementia or this is just the typical lifelong thing that I've always had. So I'm counting on that. That's what I'm counting
Yeah, I try to look at my history and hope that's the case as well.
on.
Lord.
All right, so people are jumping on. We're at 28 people. I'm going to share my screen. Can everyone see that okay?
Yep.
Beautiful.
So really quickly, then we're not live, are we?
We are, yep, we're ready to go.
All right.
Yes, so it looks like we have about 30 people joining and they're just hopping on as the webinar begins. So I think since it is noon, I will get started. So thank you everyone for joining our first of two webinars on community health workers. In this webinar, we have invited national experts to discuss the innovative work they are doing and the impacts it is having. My name is Mary Lizakowski, and I'm a Coalition Health Director with Foundation for a Healthy North Dakota. It is a nonprofit established in 2022 with a mission to promote health and wellness across North Dakota by working at the community level. We are growing a statewide coalition to enable local communities to collaborate and work together on common initiatives. And by becoming a member of the coalition, you'll be the first to receive information about educational opportunities like this one, updates on relevant public health information, legislative news, as well as access to digital advocacy resources and toolkits. Just to go over some housekeeping, this webinar is recorded. Therefore, attendees are automatically muted for the presentation. If you have questions, please put them in the Q&A or chat box, and we will address them at the end. And after the presentation, a link to the recording will be sent out along with the evaluation survey. And I did put a link to the evaluation survey in the chat too, as well. So I will turn it over to Sandy.
All right, welcome everyone. We're excited to host this conversation today. So since the Foundation for Healthy North Dakota first started, our focus has been empowering communities to promote wellness. It has informed our funding strategies, partnerships, and advocacy. From the very beginning, we have believed that community has the solution, and that has guided every action. In pursuit of our goal, we adopted an inquiry-based approach that was rooted in collaboration. We actively listen to communities across the state, engaging in dialogue to understand their needs and co-create solutions. One of the more exciting insights from this experience was the amount of organic community health work already happening on the ground. We met CHWs across the state doing this work day in and day out in their own backyards. Many did not necessarily use this title, but they were certainly performing the role, helping meet the needs of our most vulnerable residents, often under-resourced and unsung professionals who are still getting the job done. Community health workers can play an essential role in bringing these solutions to life. We applaud the state of North Dakota for recognizing this fact by passing a bill in the 2023 legislative session to create a task force to set up reimbursement for prevention services and to ensure that the community is front and center of this community work. So for the foundation, we saw two main contributions that we could make to this movement. The first was to host these webinars, which we will share some exciting work happening nationally that our state can look to for inspiration as we begin this formal journey, and some incredible innovative work happening in our own backyard that we hope to uplift. The second is to craft a CHW guide that can be downloaded from our website. This guide promotes the community focus and community health work, profiling innovations happening right here in North Dakota and the lessons we can learn from efforts around the country. And finally, if you're interested in learning more on the task force and contributing community voice to these conversations, please reach out to the foundation and we can connect you with the task force and give you dates of the next meetings. So I have heard a few names for a few years from a colleague and a collaborator at ODDUC who's really been instrumental in a lot of the work that we've done at the Foundation for Healthy North Dakota. And two of these names are presenting today, so I'm feeling pretty fortunate. So I have the great pleasure of introducing Dr. Marc Atkins, Emeritus Professor of Psychiatry and Psychology at the University of Illinois at Chicago. Dr. Atkins is the Director of Community Engagement and Collaboration for UIC Center for Clinical and Translational Science. He's an active researcher with a 3-decade history of NIH grants focused on closing the gap in behavioral health care for children and families living in high poverty communities. He's also collaborating with the National Alliance on Mental Illness Chicago on the development and implementation of a behavioral health response team for the Chicago Police Department and is a fellow of the Military Suicide Research Consortium. And Chiquitta Lesene, the founder and CEO of Shackle Free Community Outreach Agency. She holds a graduate degree in industrial and organizational psychology, the psychology people working together from Grand Canyon University. She also holds an undergraduate degree in psychology from Fayetteville State University with a concentration in human services and was a recipient of the 2023 NAACP Award for Civic Engagement and Community Service. So welcome. And then Dr. Atkins, I think you're going to get started.
Okay, thank you very much. Let me share my screen here. And assuming you all can see this.
Yes.
Good. Okay, well, thank you. It's really an honor to be here. And I'm really feel privileged to be able to talk to you about this work. I've titled this Bridging the Gap Near Peer Models to Promote Health. And what I'm going to be talking to you about is a way that we understand community health workers as near peers. I'm going to talk to you about why we use this term, how do we maximize their influence without burdening them with other tasks and responsibilities that aren't suited to their skills. And then I'm going to talk with you about, and this is ambitious, but I'm going to talk to you about parenting work that we've done over the years in some detail, and don't have a lot of time, and then very briefly, I want to talk to you about a new project on military suicide, because both of these illustrate, I think, the value and impact that community health workers, near peers, can have. So first of all, who are near peers? Well, we know these folks. We all know them. They're the people in your world you look up to, natural support who can relate to your experiences, someone to show you the ropes. They're used very often in education and common examples in elementary schools, older students reading to younger students, fourth-year medical students mentoring first-year students. And now the question is, are community health workers near peers? And what I want to try to get across to you is that they can be, but they won't necessarily be unless we're thoughtful about how we select them. So I'm going to talk to you a little bit about two major concerns in our country. One of them is the mental health of our youth, and the other will be suicide. So as many of you probably know, we do have an understanding now of a mental health crisis. It's been around for quite a few years, by the way, but COVID certainly exacerbated it. 60 to 80% of youth with mental health, with diagnosed mental health disorders, do not receive any treatment at all, and those who do, 40 to 60% drop out prematurely. Ethnic minority youth face more risk factors and even poorer odds of receiving services. This is a gap that we need to fill, and that's a lot of the work that my team and I have been doing. And then in regard to to suicide, I'm being blocked here. Let me, okay. Uh-oh, sorry. I just want to make this quick point. If you look on the left of the screen, death by all causes in the US from 1950 to 2019, what you see is this rapid decrease, this de-escalation. We have really done a lot, learned a lot about how to deal with health disorders, many of them, influenza, things like that, antibiotics and so on. But take a look at suicide. Here's the same graph across the same number of years. And this is males on the top and females on the bottom, hasn't budged. We have the same rate, in fact, slightly escalating with males across a 70-year period. And that's shocking, and that's something that needs to change. All right, now let me talk to you a little bit about the parenting work and why we think these near peers, community health workers, are so important. Well, first of all, when we think about parenting, there is some very good news. We have a long history now, more than 50 years of research on parenting programs that show a strong evidence for their long-term effectiveness with parents, including many programs internationally. Triple P is a program developed out of Australia, Incredible Years Parenting Course, and Chicago Parent Program here in the US. Have been around a number of years, and they're actually designed specifically for families in poverty. So that's very good news. That's a gap that we really need to fill. But it's still not reaching everyone. And when you take a look at what's predicting people not completing their course of a parenting program, it's the same set of issues that we know are responsible for a lot of the health disparities. Low socioeconomic status, single parent, racial minority, low educational attainment, parenting stress, and parental depression. So we're not reaching the people as well as we could, despite the evidence over the years. So our group has been asking the question, how do we fix this problem? And the answer that we're starting with is, well, who do you trust? That's Bridget, by the way, who's absolutely wonderful, been part of our team for a long time. So community health workers has been a core part of our work. They're called different things. You can see at the bottom of this slide: parent advocates, parent support specialists, family resource developers, promotores. And in fact, we've come up with a few names on our own, which I'll share with you. And what's the advantage of them? Well, first of all, there's a lot of people who are really motivated and willing to do this work. Many more than the traditional mental health providers, where we have a tremendous shortage in many areas. They can minimize social distance and stigma. They have a local knowledge of their community, and they are what we call boundary spanners for mental health providers. They're people who can help bridge the gap and build up trust in places that's sometimes hard to do. I don't have time to go over Maya Barnett's conceptual model, but I just want to point out the two things where my arrows are. As I was saying, what community health workers, she calls these lay health workers, but what community health workers can do is they can increase demand as a bridge to services, and increase the knowledge in the community of services, and they're trusting that way. And they also can increase the supply by providing culturally appropriate, by being culturally appropriate providers, people that other people trust. So this is the goal. This is what we're shooting for. What we think is what we call the secret sauce of near peers or community health workers is a concept of social proximity, identification, similar challenges in dealing with parenting in our case, ethnicity, familiar challenges arising from being part of a minority group, again, in our case, and neighborhood themes, shared challenges of facing community violence and poverty. Those are the issues that we were addressing. And you can think of those if you're not in the urban environment as I am, and you're dealing with different sets of issues. Think of it similarly: identification, ethnicity, be it part of the community, be it religiosity, and neighborhood. So I'm going to throw some quotes at you from time to time from our community health workers. I identify because I came from an impoverished neighborhood, as they say. I identify with all the crises that went on because I grew up with the crisis. The dependency on public services. I identify with a lot of the children not having a father. So I identify with a lot of different things. I came from the neighborhood where I honestly didn't know I was going to go to college because I didn't know how that worked. And we've done some research, and this is my colleague, Erica Gustafson, who's done some work showing that the barriers that we know are identified on the left, logistical, cultural, systemic, lack of parent engagement, a shortage of providers, can each be addressed very systematically by involving community health workers and giving them the right kind of support and training. So here's some more quotes. Serving as advocates between schools and families. Yeah, because the teacher is trying to do her own thing. The parent is trying to do her own thing and trying to get through all these obstacles and hurdles that life is throwing at her. And then you have a child who's in first grade and does not know a single letter, you know? This is a school-based project we were working on. We are advocates for everybody, for the family, even for the teachers, for the administration at the school. We are, in essence, advocates because our role says that we're going to support in absolutely whatever way we can. These are quotes from our community, and you can see why we value them so much. This, the advocates, is a really good example of a boundary spanner, someone who sees themselves as crossing over. I think it's hard to have some of those conversations with parents because growing up in this neighborhood, the reality that is that if the kids, especially with behavior problems, don't get it together, they're either going to end up dead or end up in jail. I worked there for a while, even before joining PASS. That's our project I'll describe in a minute. So I knew the dynamics. I knew the people, the staff and everybody. We were a turnaround school. This was a concept in Chicago that was trying to make schools that weren't doing well do better. We were a turnaround school, so this school was kicked out and then comes in another school, but everything is so different and for the worse. This is how the community is seeing these turnaround schools as being, they lose their school and then they get sent to another school, but they don't know these folks. And our point is that the community health workers are the people who know this. They've lived this with the parents, so they can really relate to it. So I want to talk to you quickly about a project that we call PALS, Parents as Leaders in School. And on the left, you can see a graph that shows on the top are the parents, the percentage of parents who received and stayed in our program up to 12 months later. And you can see more than half stayed for an entire year. On the bottom are the parents who were referred to clinic. You can't see it. It's a dotted line because it's 0. A few of them started it, and then they didn't stick. And this is what we were dealing with. Now, on the right, I want to show you how we addressed this. We had 3 schools, and our idea was this wasn't going to be solved by one type of problem, by one type of solution. It was going to be solved by giving parents access to a number of different ways of getting involved. We held school events, we held groups, but I'm pointing out the role of our community consultants with my arrows. Remember, that's what we call them. They're community health workers, but we gave them that name. They did home visits with the social workers. They were teamed up with the social worker. And they also provided direct contact with parents. And that's what the white parents. And that's what we think was responsible for the high rates of involvement. And then we followed that up in a larger project a few years later that we called PASS. And there we had 4 agencies and we had a staff of community health workers. They named themselves School Family Liaisons. Again, they're a bridge with 8, they're paired with social workers. In 16 schools, we had over 600 families in this project. And you could see the way it was structured. Each school family liaison had about 20 students and families. So what was important to us was to first start out, and this is the part that I really like to emphasize when we're talking to folks. We don't just bring community health workers on board and say, go do your thing. We work with them to help them identify what are the core values of this program and what are your core beliefs. Consistency. Don't give up on parents. You have to keep trying. You keep trying. Just keep trying. Just think about yourself. If you have this wall built up, somebody's going to have to keep trying to break it down, and that's it. this was a core belief of our community health workers, to keep going, to never give up on a family, and to make sure that we were focused on the core values: family-centered, strength-based, community-connected empowerment. You come up with your own values, program values for your own program. These are the ones we came up with our group. And then again, as I was saying earlier, the parents' goals are the same: support learning at home and school, develop parenting skills, address family needs. But the service format was very flexible. We didn't just have parenting groups. We had home visiting, we had case management, and we had individual context. And what that resulted in is something that we never see with parenting programs. First, this was a group of parents who stayed low. That we do tend to see. This is a group of parents, they start low and they stay low. But then we had this other group of parents that started high and then stopped coming for a while, but came back up again. And that's what we very rarely see. When you're doing a parenting group, if you stop coming, typically you don't come again. But our community health workers stayed with them and kept them engaged. And then we had a group, and this was what we were very proud of, started with nothing. They didn't get involved at all, but our community health workers kept working with them, and they came out as the stars of our program. And then here's another group. We consider this group just staying pretty high throughout. Those kind of different trajectories point to the fact that different parents have different sets of needs. Our community health workers were well-versed in providing the kinds of services that the parents need. All right, so that's the fastest I've ever presented that parenting work, but I just want to take the last few minutes to talk about military suicide, which is a project we're working on right now. We're working with the the Idaho National Guard. And again, what I want to show you here on the right, you can see the U.S. military suicide crisis. So on the lighter bar are levels of suicidal ideation prior to them being involved in the military. And the darker bars are post-service. And, you know, a lot of this was going on as we were engaged in wars overseas. And you can see that's an extraordinarily high rate of suicidal ideation. And that's why we know there's a military crisis, a military suicide crisis. As it turns out, Idaho National Guard has the highest suicide rate in the country, probably because it's rural, it's poor, and there's a lot of guns. And that's what they've said to us. That's what they think is going on. And when we got there and we started working with them, we found out that they were starting to work with what they call the first line leader training program. And they were using this total health. I'm going to describe that first line leader in a minute here, but they used a total health program, total health model. This is Idaho, okay? Wanted their soldiers to understand there's a lot of things that impact on their health. These are a number of things that can lead to some kind of a life crisis. So we applied for a grant from the Department of Defense, which we received, and it's going to be starting this fall. And the goal is to intervene before these problems escalate. And this first line leaders program that Idaho is working on, the national office of the Idaho National Guard said they want this to go national. So we're both nervous and excited that if we can get this working, this is going national, and this can really hopefully make an impact. So let me just describe this really quickly, and I know I just have a minute or two. So this is the way a battalion is set up, with companies and platoons and squad sergeants. And then under the squad sergeants, you have these non-commissioned officers, right? And these are the people, each of them have 10 or 15 soldiers under their command. They are very well respected. They're people who started out. Remember, they're non-commissioned. If you know anything about military, they're not ROTC. They didn't get, you know, formal military training. They started out as grunts, just like these folks, and they have a lot of respect. We think these are exactly the kind of people who can make a difference on suicide prevention, and we call them near peers. They have an elevated status, but they're coming from the same peer group as the soldiers who we are so worried about. First line leaders, I won't be able to go into this, but there's a number of phases to it. It's going on right now: motivational interviewing. They want to monitor, so they're assessing programs, and they're rolling it out across units. They're getting volunteer units. And we're going to be building our program on top of that. And we call it a total action a total health action plan, working with the non-commissioned officers to not only talk about total health, but what do you do when a problem comes up? How do you address that problem early? And these are the skills that we're teaching them. We think they are exactly the right people to be doing this. They're the people that have a lot of influence. So I'm going to stop here and just end it with persistent health disparities require new approaches, especially for behavioral health concerns that have shown little change, such as mental health and suicide. Near peers are common in education and becoming more common in healthcare, but are still underutilized. We've shown that community health workers, when paired with mental health, when paired with social workers, are more effective at reaching parents in traditional clinic-based care. Military suicide is in high need for new approaches. Can near peers make a difference? Last point, near peers need support and guidance to identify core values that align with program goals and bring out their strengths. So I'll stop here. Thank you.
Thank you so much. Chiquitta, we can transfer to you.
Awesome. Hello, everyone. Thank you for the opportunity to present. I hope that everyone can hear me okay. If you can't, just let me know. I do speak a little fast, but I'll try to slow down. I just want to first start out with saying thank you to Dr. Atkins for providing such a great foundation on our valued community health workers, community health ambassadors, community health consultants. Those are the people that wear their tragedies as armor, not shackles. That's an anonymous quote, but I love it. It absolutely speaks to exactly what we do at Shackle Free. Welcome to the Shackle Free experience. I am Chiquitta Lesene. I want to thank you for the opportunity to share our vision of how to achieve holistic health and wellness in historically marginalized, rural or urban BIPOC communities of color. I always like to start with our reason why. I think that sometimes we need to take a trip back to just remember why we do what we do. And sometimes the end result of not being able to have things in place, the inequities that we all know of and that we see and that we witness. This picture to the left shows you some young men in our community that had passed away. Most of them were under the age of 30. And this picture just shows of a fraction of those young lives that were lost. But in total, we're up to about 40 and the numbers continuing to grow. So as we continue to look at exactly what we do and why, I want to take you on a trip, give you an opportunity to witness the Shackle Free experience. And so I'm going to start with this video that gives you a little background on what we do and how we do it and why.
75% of African American men and women are likely to develop high blood pressure by age 55.
Top killer of Black men in America. It's becoming more and more prevalent in younger age groups.
Prostate cancer is killing Black men faster than it's killing men of any other race.
More than 40% of Black men have high blood pressure. As a result, African American men are at greater risk of having a stroke than any other group in the United States. Twice as likely as compared to white men.
More likely than your white friends to develop kidney failure. And if that doesn't shock you enough, about 90% of us with kidney disease don't even know we have it.
Diabetes impacts more than 34 million people in the U.S., and 1 in 5 Americans don't know they actually have it. But according to the American Physiological Society, Black people make up nearly 12% of all cases compared to 7.5% of whites.
Out here and do a survey. Asked 100 of us, all Black males, how long has it been since they've had their blood pressure checked? And I bet you, some of them will tell you years.
With the life expectancy of Black men decreasing rapidly, preventative health measures are more important than ever before. While we all want to live healthy lives, medical care is not always priority, whether due to affordability or fear. Shackle Free Community Outreach Agency Incorporated presents Amsterdam, a Shackle Free Buzz initiative highlighting awareness and prevention within the community with the assistance of our trusted messengers, our barbers and stylists.
Se ve Hello, I'm Chiquitta Lesene. I'm the CEO and founder of Shackle Free Community Outreach Agency Incorporated. We're here today. We're having our first pilot episode of the Shackle Free Buzz. The Shackle Free Buzz utilizes beauty and barber institutions, and we're located at Heads Up Barber Academics Company in Jacksonville, North Carolina. And again, we're here to put on our pilot episode. It's called Amsterdam. And again, what it does is connects our medical providers with our barbers and beauticians who are trusted messengers in the community, coming together to answer questions on panels about health issues as they affect men and things like that. So we're excited about this pilot episode. We're excited about the entire initiative. We're excited to know that our barbers and beauty shops are our trusted spots in the community, especially in historically marginalized communities.
The relationship between barbers and medical professionals dates back centuries. Prior to the 19th century, barbers were known as barber surgeons and conducted many medical procedures, including bloodletting and even amputations.
Basically, barbers relate to the medical field because back in the early times, most of the barbers was barber surgeons until they separated two professions. When I say barber surgeons, we perform minor surgeries like tooth pulling, amputations, and stuff such of that nature. We also have a relationship with most of our clients. We're the trusted messengers in the community, so a lot of our clients feel safer talking to us before they talk to anybody else. Of course, they come to see us once a week, twice a week, once a month, all throughout the year. So we try to use use our skill and knowledge to educate our clients on stuff like cancer, diabetes, stuff that's been killing people in the colored community a lot faster than the other people. So we want to try to continue to educate our clients. Like today, we bring the doctors in so they can educate the clients on stuff about health.
The Shackle Free Buzz initiative will utilize trusted messengers to promote preventative health within the community. Episode 1 of Amsterdam featured a panel discussion with community leaders including Dr. Johnny Williams, Councilman Brian Jackson, Pastor Christopher Rose, Mario Harris, founder of MENAC Incorporated, Football Hall of Famer Demetrius Hardison, Greg Shanson, Physician's Assist, and Shackle Free's own Sherry Harris and Sherry Tukes. Community involvement is all-encompassing and includes tools for proper communication and, first and foremost, good nutrition.
Absolutely, because what we can do either way is make sure you have some healthy, fresh produce. We got to get more in tune with eating healthy. It helps you to think better. It clears your mind. It helps you to move around better and do all of those things.
The mission of Shackle Free Community Outreach is to provide a holistic approach, mind, body, and spirit, to the barriers that prevent individuals and families from reaching their whole potential. Early detection is prevention. What better place to tackle the onset of disease than the lifelines of our community, our local barbers and salons? In addition to physical wellness, good mental health starts within the home. Shackle Free's Good Daddies initiative is a mentorship program that supports young men to overcome the obstacles of fatherhood.
I am strong.
We kind of want to try to educate him on stuff that I was trained or stuff that I went through so he don't have to go through it. This is a form of leadership that we need to take up the role in our communities. Instead of, showing them the wrong way, let's show him the right way so he can be a great dad to his child.
Shackle Free's Amsterdam initiative focuses on health awareness, communication, mentorship, and nutrition to tackle the barriers we face as a community. For more information on how to join the Shackle Free Buzz, visit shacklefree.org.
So our methodology behind this is that we believe that evidence-based and strengths-based practices combined with lived experiences from trusted messengers like our barbers and beauticians with trusted messages is the solution to eradicate poverty. So let's make it make sense and sense for the collective. And if you've done what if you do what you've always done, you're going to get what you've always gotten. And so now what we're seeing in this environment that we're currently living in is that we do have to have some type of structure, and again, knowing what our why is. And what we use at Shackle Free is the aroma cycle. I am a national certified aroma trainer. I'm going to go through these steps briefly as I go through the slides, and you'll get to see each cycle in action. The first phase of this cycle is the assessment. We gather the community's needs and resources and bring those together and create a plan. And first, what we decided to do was to give our community health ambassadors a better definition to really hone in on what they are. They are village-centered individuals with lived experiences, with a strong in-community rapport and a desire to make a lasting impact toward population health and holistic well-being. And during our assessment process, we also put together this model. We had the You Are Well North Carolina model. And with that model, we were able to capture the data and actually apply and create programs within our agency that provide the services that you see here. And again, these slides are going to be shared, so I won't go into each one of those, but we have something that hits on everything. What we know is that health is more than an absence of disease. It's about jobs and employment, education, and the environment, and all of those things that go into making us healthy. That's a quote from Joycelyn Elders. Again, what we also see during our assessment is that there aren't enough opportunities available to our youth across the country. And utilizing our barber and beauty shops, that actually helps to create that, that connection, an intergenerational connection, because most of the time you're with your barber or your beautician for life, unless you relocate to another area. Those are your trusted messages in the community. Looking at this slide, we see that everybody plays a part in health. Trillium is our LME. They're our local mental health provider. And they designed this graphic, and I love to use it because it shows how everything must come together. Whenever you're trying to build up your community, we need to have the school system in line. We need to have them at the table, transportation at the table, people with access to food at the table. Everybody plays a part in it. Our government officials, community partners, everybody plays a part in creating a healthy community. So during our planning process, which is the next step in the cycle, we decided to use our mission statement and use the assessment data to create some strategies. And we came up with the Shackle Free Buzz, where we would train our barbers and beauticians and give them all of the education that they would need. And not just barbers and beauticians, but this is anybody in the community, anyone with lived experiences. But we started bringing in these barber and beauty shops because there's one on every corner in every county, every community across the country. So this is something great to be able to duplicate and share, like we are doing right now with our friends in North Dakota. But what we also learned was that if people have access to resources when they go get their haircut, they're more likely to utilize those resources if they're in their barbershop versus the community colleges, right? And the libraries, where we see most of the resources go, are into those places, but are those places really the places that people frequent? And hopefully our outcomes will show you that we've already mastered that. The answer to that question is that people visit their barbers and beauticians 20 times a year, and they may go see their medical provider one time at the encouragement of their beauty provider. It all makes sense. I'm going to go past this video for time's sake, but it will be available in the slide.
Hold on here. Is it the barbershop? Is it the barbershop?
Yes, it is.
It's the barbershop.
Yes.
Well, I mean, we can't talk straight in the barbershop. Then where can we talk straight? We can't talk straight nowhere else. You know, this ain't nothing but healthy conversation. That's all.
For that.
So just taking that little clip off of Cedric the Entertainer from the Barbershop movie, we decided to give our barbers and beauticians training on everything you see over here to the left. I know maybe a little small, but you've got healthcare, cancer, vaccines, digital equity. everything holistic, everything that applies in this pyramid here. That's our good friend Abraham. We love him dearly at Shackle Free. We believe that people cannot rise from crisis to thriving unless they're able to follow that pyramid. We can't expect for people to know how to make good decisions in any environment if they're hungry, if they need somewhere to live, if they have family issues that have created dissensions and division within their families, if they don't have that actual support system, or if they may have been, wounded with self-esteem and confidence, but to help them rise to that level at the top of Maslow's, we utilize our barbers and beauticians that can constantly and consistently provide these actual some input and insight with training on the things that affect their clients that they see more often than anybody else really sees them. These are some benefits to utilizing our community health ambassador model. We also have a community health ambassador call center that is staffed with individuals from the community, but it provides these benefits that you see here to the right. It alleviates these post-pandemic challenges. It transforms the vital role of the community toward population health. It's not just about my county, it's about the country. It's about North Dakota. It's about South Carolina. It's about California. It provides immediate contact. And not only that, you guys, out of all of these things, it also provides and empowers people who live in the community to remain there if we can, of course, be able to support them with a living wage, which is something else that we are working on. So we got them trained. We partnered with Duke University, and we currently have 101 community health ambassadors, the majority of them being barbers and beauticians. Here's another slide about that program. If you're interested, anyone can attend this training, or we can help you to get signed up for it. But we created the Barber and Beauty Edition, again, to just remind everyone of how much of a holistic space that our barber and beauty shops are. We also install wellness kiosks that allows someone to go to the kiosk and be able to connect with a community health ambassador without doing so in public where anybody can hear them. They can do it right there, and then we'll contact them at a time that's safe for them. What we did see was that domestic violence rates increased after COVID. And so we want people to be able to have a safe space. But that kiosk has a lot of things on it. It's not just our holistic screener, but it also has apps for the barber to allow their clients to go set up the next appointment and things like that. 211, a lot of things. And then we also have binders for those who didn't want to use the kiosk. Here's some more information on our community health ambassador training and sign up. And then just going back to, since we're in the implementation phase of that cycle, implementing whatever it is that you're working on in your community can make this thing work. So let's look at some results real quick. I'm going to skip that video just for time, but that video showed Dr. Samava Sahab. She was presenting to the to the White House American Rescue Plan Act committee. She was presenting to them, and she mentioned Shackle Free and the actual initiative that we have going on with our barbers and our beauticians. But this gives a program snapshot of the outcomes that we've had by partnering with our barber and beauty shops and our faith-based organizations, civic groups, and all of those individuals. But we were able to give out 103,000 pounds of food. These numbers have changed since the slide was produced because we're doing this every day. Here are some more stats and some additional stats. We were able to administer about 5,300. This slide is a little out of date. To COVID and flu vaccines using our barber and beauty shops to help us promote that information. What we're looking for is the opportunity to expand. This initiative works. It's evidence-based, it's solutions-focused, it's people-driven. We want to expand it, and we also utilize it for capacity building. A lot of our smaller community-based organizations, just like Shackle Free, we don't always have unrestricted funds, or have not gotten to the point where the foundations or people just know that we need you to unrestricted funds. So we're looking to partner to help to flip poverty across the country. Here are just some other flyers that I'm going to share with you as I end my presentation, just showing you us out in the community and how we utilize our barbers and beauticians.
Hey everybody, Chiquitta Lesene, CEO of Shackle Free Community Outreach Agency in
We are also partnering with some academic institutions such as Duke. We just presented to them as well. Here's some photos from that academic and partnership discussion featured here, promoting the buzz. Same thing with voter registration. We have an election coming up this year. We want to make sure that there are nonpartisan information going around in our communities just about the candidates and different things. We also just had a presentation by Dr. John Murata. He presented to our barbers and beauticians about long COVID to make sure that they're up to date and ready for that. This shows a community consultation studio that we just hosted in our barbershop over here to the right at Herring's Barbershop. We hosted that about Medicaid expansion. So again, any initiative that we're working on, we use barber shops. So I just wanted to end up with a little cheer here to take us on out. All the folks you love together, sitting talking about. I'm going to stop there. Thank you so much for the opportunity to present.
I was starting to dance a little bit. So thank you, Chiquitta and Dr. Atkins, for sharing your amazing work. It's just really moving, and I'm excited to see how we can use this in North Dakota moving forward. So Mary.
Oops, sorry, I was on mute. All right, we can move into questions that have come in. And additionally, there is a QR code to take the evaluation survey when you have a moment. So we do have one question that came in, and Dr. Atkins, I believe this is for you in one of your beginning slides. What happened in the late 1900s to attribute to the decrease in suicides, and is it something we can do again now?
Yeah, sure. I saw that. I didn't know. Can I share my screen and look at that slide?
Absolutely.
Okay, let me just do that really quickly here. And I need to get, whoopsie. That's not going to work. I'm sorry. Maybe it's not. Maybe it's right here.
And we have time, so this works too.
All right. I'm not sharing yet, am I?
Not sharing yet.
But I am now.
Yes.
So let's take a look. That was a perceptive question. I don't know if you could see my cursor. Can you see my cursor?
Yes.
Yeah, okay. So that's what I guess we're talking about, the dip right here, which actually was a little bit of a bump in the 90s. So the short answer is I would have no idea. There's nothing in the literature about that era that jumps out at me. But I will say this is often in the epidemiological world called an epiphenomenon, meaning it's something that happened that may or may not be related. It may have been related to perhaps there was crack cocaine going on at this point, something like that. Just like the opioid crisis is what's led to this large increase, this slight increase right here, and so on. If we could figure that out, we would be doing it, I'm sure. But I think the short answer is that it's probably not anything specific to suicide prevention, but something more community related. That is just something, a little blip in the data. But I think the overall point is that things have not de-escalated very much. So I'll stop there.
Okay, that makes sense. Chiquitta, I have a question for you. When you started working with barbershops and beauticians, how long did it take you from the conception of the idea to application with the training? And then what has been the initial response from community members regarding that?
So I would say the concept came in about 2018. I was a kitchen hair person, which means I did hair in the kitchen from about 12, 13 years old. So I always knew that relationship was there. But then, you know, you grow, you go older, and then you just forget about the simple things. So I think the concept came about, and then 2019 is when we set up Shackle Free, and we started doing a lot of community events and just looking for places, right, to utilize that people actually frequent, the people that we were trying to reach. We were having a difficult time coming up with that. So we really just had to start thinking about it in a different way. So we started thinking, and we said, you know what? We were in Warsaw. We're going to go check out Wildcats. That'll be our first one that we'll do, is about giving away food. And so we went to the barber and talked to him and everything like that. Very receptive, already had an audience, the go-to place already. So we did that, and we just noticed this is working. So we just started continuing and doing that process. Now the co-founder of Shackle Free and our chief operating officer is a barber, and he's a barber instructor. And so everything just started coming into play, just started making sense. So I would say about 2 years to really get the word out, because we're constantly utilizing the barbershops for different initiatives, like once a month. You know, we're needing to we have a 5-county area that we're serving. So we're jumping around from barbershop to beauty shop. And then we were contacted by Duke about the Community Health Ambassador program. And so we were like, well, wow, you know, it makes sense if we will use our barbers and beauticians that have been partnering with us already to give away PPE, to give away masks and COVID-19 tests. We had little small hubs set up at the barbershops that would give people access to things that they needed immediately during COVID. And so we started reaching out to the barber schools. And we were able to get like 3 barber schools, the entire the classes, day and evening light classes, certified. And they just started, you know, practicing. So I would just say maybe 2 years to get it up and running and smooth. But now that we know what we're doing pretty much, it doesn't take us any time at all. We actually use data to analyze the hot spots for where we need to place these services, and we intentionally address those barber and beauty shops that are in the area that have whatever it is we're working on. If it's Medicaid expansion and we're looking for low to moderate income women, then we would look for a beauty shop that's located in that area. And that's the model that we base it on. We do the community assessment, and then we do the mapping, and that's where the consulting on our end comes in to just help organizations that are looking forward to trying to look into barber and beauty shops, because honestly, people are not going to libraries and community colleges. A lot of the populations that we're trying to reach don't frequent those places. And so that consistency is not going to be there. If I go to the gym one day and I don't go back again for 20 days, that's not consistency. But if I'm doing it every day, I'm going to see results. And so seeing the barber and beautician once a month is even more emphasis than what we currently have from those other places where the money is being invested into. And I feel like for a long time, a lot of dollars have been wasted by just not putting information where people can access it. Did I answer your question? And
you did.
No challenges really. Just the barbers don't have the time sometimes. Okay, so we use them. I can't give you a challenge. Supporting the barbershops financially. They're paying their own utilities and rent, and some of them are paying barber booth rent. The challenge is when you have a barbershop that's super busy, you can deliver the messages for you. But in my mind, that's almost like a using type thing. And I don't want to take advantage of people knowing they already talk to people. Yeah. So why not have them as essential workers? Why not looking to see if they can be billable with Medicaid or insurance, serving as navigators, because we're already doing it.
Yeah. That makes sense to me. And I think when we were preparing for the for this webinar, we talked about it, and I was thinking, my beautician was invited to all my children's graduations. So I was starting to make sense to me for sure. And then Dr. Atkins, when you were talking about the parenting program with community health workers, really connecting the home visiting, maybe the parenting classes, but also hosting school events. How were those other players and, kiddos and families' lives appreciative of having that connector with everyone?
Yeah, I think the point about the home visits is interesting because not everybody wanted someone coming into their home. And so that's the point about the flexibility. Some parents would prefer to meet at the school. Some parents would prefer to meet by phone, and that's what that's not typically what a mental health provider would do. Mental health provider would sometimes social workers do that kind of flexible service. They're probably the lead in the professional community that way, our case managers. But the parents who did appreciate, and you could see from that graph that there were a pretty decent percentage, and it differed across the schools. The parents who did receive it did really appreciate someone coming in, particularly someone like our staff who were from their community and understood their needs. They weren't coming in there to lecture them or take anything away from them, which so often happens with social services, but actually just figure out what the needs are. And the last thing I'll say too about that, or one other thing, is that they were often coming to tell parents how their kids were doing in school, and parents really appreciated that. We talked about that as someone having the parents back, that the parent couldn't be in the school, didn't know what was going on, often didn't have good relations with the school historically. The African American community in Chicago especially has struggled with that. And our staff, community consultants, or sometimes school family liaisons, whatever we wound up calling them, were often there to tell the parents, hey, I saw Malik at school today, and I just want you to know he's working on his ABC. Parents really appreciated that a lot. We found that in our follow-up data.
That's great. Yeah, I think that's such a good program as well. And especially your work in Idaho with the National Guard. That's all, I think.
I want to say
excellent.
quickly,
Yeah.
Sandy, that I saw a question about standards as a question about some work being proposed in North Dakota, which sounds important. And I just found really quickly a SAMHSA review of national standards for training and support of community health workers. So I stuck that in response to the question. There's much more that needs to be done, I know, but that was one thing I could do really quickly. So I just wanted to say it's there.
Oh, there it is. Okay, great. Thank you for that. So thank you both. And then Mary, I will let you finish up. And just a follow-up, next week, we're hosting another webinar, the same topic, but talking to community-based organizations within North Dakota that are doing this work, and to get more information out there. So Mary.
Yeah, so we had one other question that came in during registration. And it was, did you use journey mapping in the process? And I do see this person is also online, so maybe they can elaborate if you need any more information on that. But
was that for Chiquitta or for?
Yeah, that's yep, that's so this is yep, Peter Durand. So that is his question. Did you use journey mapping? Yeah.
That was for me. Could you elaborate a little bit about journey mapping? I'm not familiar with that term. If possible.
Okay, we have been using visual journey mapping in Houston for CHWs. No.
So it may be the same thing as what we refer to as a success toolkit. I'm wondering if that's something similar. Visual pathways to identify training. Yes, absolutely. But we call it success toolkit. That's what we call our planning process. But yes, we did create some visual pathways. I gave you one diagram that we utilized to show how we break that URL North Carolina initiative down into subgroups. So that's one thing that we did, and also utilizing the statistics, of course, the community needs assessments that are completed by counties. We use that. We also use a lot of statistics, community town halls, consultation studios, surveys, questionnaires. We're always doing surveys in our community and creating health equity teams as well. And the health equity teams that we create also fall along the line. But I like that term journey method. I may steal it if it's up for steal, if I can take it.
Awesome, thank you. I don't see any other questions that have come in. Dr. Atkins, that link, it doesn't look like it hyperlinked, but I can try and find.
Sorry, yeah.
We can, so when we send out the email after the webinar is over, we can make sure the presentations and the links are embedded into the email. So that's for everyone that registered. So.
Yes. All right. I don't see any other questions, so we can move to wrap up. All right, so thanks again for to our presenters and everyone who could attend. To stay connected with us, you can follow Healthy NODAC on Facebook, Instagram, Twitter, and Foundation for a Healthy North Dakota on LinkedIn. And also to join the coalition, you can visit the link to stay aware of future webinars and updates on the foundation. And again, there is a QR code on this slide and also a link to the CHW guide, which is also located within our reports on our website. So, and that will link you there, and all this will be in a follow-up email. So, all right. Well, thank you, everyone, and enjoy the rest of your day.
Thank you.
I know.